Nurse Leader Implications for Medical Legal Education is our episode topic. Rejoining us as guest is Dr. Lisa Wolf, a tenured professor at the University of Massachusetts Amherst. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Well, Lisa, thank you so much for joining us today.
Thanks for having me.
You most recently published an article. You publish a lot of articles every year, but you published a new one with some ethical implications for nurse leaders that we need to be aware of. Tell us more about it.
Yeah, so this is a study that I did through my work at the University of Massachusetts in collaboration with a linguistic anthropologist named Lynette Arnold. And the two of us had been working on some other conversations together. And I was telling her about the work that we had spoken about earlier about moral courage. And she was like, wow, that's really interesting. So we started talking about the extension of that work. And she's like, let's take a look at this together. So this is a study that's done from really good perspectives that align very well, anthropology and nursing. And so this is a study about across the number of studies that I've been working on around how emergency nurses manage obstetric care in states with abortion bans. It's like the arc here. What came through in all the studies that we'd done up to this point was that nurses kept saying, nobody's telling us anything. Our leadership, our administration, there's no policy, there's no communication, there's nothing. And so they were feeling confused, challenged, didn't really know how to approach patients, didn't really know how to approach the problem, didn't feel like they could ask questions. And so we decided to explore this a little more rigorously. And so we recruited 23 nurses from states both with and without abortion bans. And it initially also included gender affirming care, but it really focused down onto really the management of obstetric care. And so we asked them, like, what do you know about the legislation in your state? What do you know about limitations on reproductive health care? And about 30% of people had no idea that there was any legislation around this in their state. The laws themselves are very problematic because they're written very vaguely. What we're talking about here, essentially for the inpatient setting and for the emergency care setting, is not elective abortion, right? That's not what we're talking about here. That is a slightly separate conversation. What we're talking about here is patients who come in with pregnancy complications or postpartum pregnancy complications, right? Miscarriage, fetal demise, sepsis, cardiomyopathy, pulmonary embolus, preeclampsia, eclampsia, right? Life-threatening things to the pregnant person. And while most states' legislatures offer some reference to exceptions for life or health of the pregnant person, nobody's really clear on what that is. And because the stated penalties for a provider to provide abortion care, somewhere in the neighborhood of $10,000, 10 years in jail, delicensure, right? People are more hesitant to act when in states where there are these bans, they would follow the standard of care as very clearly laid out by both ACOG and the Society for Maternal Fetal Medicine. These are very clearly laid out standards of care for people experiencing pregnancy emergencies, and they are not being followed in states with abortion bans due to the fear of nobody really knows like how close to death do you need to be before you can provide care to somebody who needs it.
I suspect, maybe I'm going off on a tangent here, but I suspect that in some of these institutions where the nurses and the doctors don't understand what the actual laws are, that if and when they're in a situation and they're trying to seek clarity, that some of the hospitals like to have some general counsels that give wishy-washy answers that don't really help you out. And was that part of your study of exploring that or
I think the challenge was that nobody knew what the process was, right? So we're speaking to nurses only.
okay.
And so we spoke to not just staff nurses, but also like educators, people who are responsible for educating the staff around policy and practice changes. And they all said, we don't know. And every time we ask our administration, they're like, we don't know. We'll get back to you. And so it leaves nurses in a place where they are very reluctant to have the conversation. Like this is one of those conversations that you should have well before
The
a
patients
patient
in the
comes
door.
in
Yeah.
who is bleeding out. But those conversations are not happening for whatever reason. And there are a couple of reasons that nurses theorize, and I can't speak to the validity of these, but the perception from the nurses on the ground is that administration doesn't want to engage with this. They're hoping it just goes away. They're reluctant to make a policy because the policy can now be held up as a standard, and that can change. But stands are shifting all the time.
Yeah.
And that's part of the problem, right? So when the Dobbs decision came down, there were all these trigger laws that went into play in a lot of states. And so those have been interpreted to apply to people who need care for their life-threatening pregnancy emergency rather than an elective procedure or medication, right? So no one's tested this is the thing. And I can understand why providers may not want to be the test case. But in terms of if you think about tort law, right? Anybody who works in any kind of risk management, if you have a duty to provide care and you breach that duty and harm comes to the patient because of that breach of duty, you are liable from a professional standpoint.
So if I'm a leader in one of these states, or if I'm a leader in any state right now, we've got this study right now that's talking about that they report anger and frustration about the information. They don't know what to do. Clearly, the solution is to figure out what to do and to provide it. That's a key takeaway. But if I don't have general counsel that's willing to take a stand, put a flag somewhere and answer those questions,
Right.
as a nurse leader, I can only advocate so much, and I need to lean on risk management, general counsel, and
Right.
or a combination of both to say, this is what can be done and what cannot be done. And this is what the policy needs to be. So what do I do? Because the hot potato may not be coming from the leader. Maybe I'm doing all I can. Legal's not doing their part.
And I think again, because it's so vague, right?
Right.
So if you want, for example, so let's think about a state where the divorce is banned. So there's not just more people who are now pregnant who may or may not want to be pregnant, but there are people who should not be pregnant due to pre-existing medical conditions who now must remain pregnant. So you've got a bigger, sicker population of pregnant people. And the United States has the worst maternal mortality in the industrialized world. We are
Yeah.
terrible at this. And then layer onto that an emergency department where nobody gets obstetric education in the context of expanding obstetric deserts. So in a lot of places, you have this perfect storm of more pregnant people in a place without obstetric care who are presenting to a practice setting where nobody has any education, has really not thought about the care of these patients. And we've got all these vague laws that really impede our ability to cut through kind of the garbage and focus on the patient, right? So if you have, for example, a patient comes into your emergency department, 17 weeks pregnant, water breaks with
Yeah.
ruptured membranes.
Yeah.
A pregnancy will not survive. Will not survive. And if you're in Massachusetts or you're in Maine or you're in Vermont, they will remove that pregnancy so that you don't become septic. If you're in a state where there's hesitation because this doomed pregnancy still has some kind
Texas
of
or
cardiac activity.
Idaho, for example, right?
Exactly. So if the fetus has a heartbeat, you got it. Their understanding of that law is you must wait, regardless of what happens to the pregnant person, before you act. Right? So this is where we get women bleeding out in parking lots, returning with massive sepsis, losing their their reproductive capacity, right? Because no one's really clear on how close to dead is dead enough.
As you're talking, it's making me think a little bit about, I don't know whether double standard is the right word here, but if we were not talking about a fetus for a moment, if we were talking about an adult, an 86-year-old male that comes in that is intubated in the ED, we can't get a hold of family, they're a John Doe, right? And we know that we're not going to have a good outcome on this patient. Usually, especially let's say that they have a living will, it's two physicians, right? Two physicians that can say, this person's not going to survive. We're going to go ahead and withdraw care.
Right.
What's the difference between that, and why isn't that a similar standard applied when we're talking about fetuses that are not going to survive? That it would be two independent physicians that could just say, this fetus is not going to survive, therefore we're going to
We're going to
protect
end the
the life of the
pregnancy and
mother.
preserve the life and health of the person who's
Yeah.
pregnant. Exactly. It's a really good question, and it is so tied up with
And I used living will as an example, and that would be someone being informed consent to say, this is what I want. Let's just take that out of the question for a moment, because even if it wasn't a living will situation, if you've got someone that's unidentified, you know that this person is not going to survive, they're not going to have a good outcome. At what point in time do you withdraw treatment? And in many cases, two physicians would work
Right.
in that scenario.
But this is also not a case of withdrawing treatment from a pre-viable fetus. This is providing care to a living, breathing person.
Fair point.
This for
Yeah.
fate. So there's this challenge, especially in places like Texas, where fetal personhood is like they're trying to make it a thing. And then you would not be able to, then you would have to balance the care of the fetus, who in this case will not survive, and the pregnant person. And there are opportunities for pregnant people to make choices around their care, right? And if a person is presented with all of their options, like we could do this, we could watch and wait, we could remove the pregnancy to preserve your health, we can watch and wait and see what happens. Here's like what this looks like in the grand scheme of things. You get to choose. That's one set of circumstances. But what is happening in states like Texas and Idaho is that people are not being presented with that option. They are basically told, go home, follow up with your OB, and if you spike a fever and start to like model, I guess, come back to the emergency department. No care is provided for these patients. And that's really scary, especially when, as emergency nurses, like up until 2 years ago, everybody knew what to do in this case. Take that patient to the OR and you keep them from going septic. And now that's not an option. And there is not a lot of strong pushback from the AMA, from ACOG, in a meaningful way that says this is not acceptable. The only thing that those physicians can do is vote with their feet, which is why Idaho has lost 30% of its OBs, which makes the problem even worse. It is incredibly difficult to recruit OBGYNs to states with bans
Yeah.
because they can't provide appropriate
practice.
care for their patients.
Yeah.
So where this comes back to this idea of what are the ethical obligations for nursing leaders, there's a provision in the ANA Code of Ethics that requires that all resources be provided to nursing staff to provide safe care, and that includes information. And so by not discussing, by not speaking about this very important practice change for a lot of people, you're not just denying nurses information, you're denying patients information and appropriate care. So this is really not just like a clinical problem. This is also a disciplinary violation of ethics that I think people don't understand as a professional violation. They see it as, what am I supposed to do? It's illegal. But when we ask nurses, what happens when you change your door to EKG process? What happens when there's some kind of practice change? We're going to use a new AngioCat. This is our new way to send people to CT when they present with stroke-like symptoms. And they all said, there's an email, there's a meeting, we have to sign off on the book, there's posters in the bathrooms, there's posters everywhere, right? All the information is happening from a huge variety of sources. And we said, what's different about this? And they all got really angry. They were like, right, what is different about this? This is significant. if you're telling me now that I can't tell a patient where they can get care and I'll go to jail, like I need to know that, right? I need to know what the interpretation of how this institution is interpreting this law and how it affects my practice and how it affects how I can care for my patients.
All right. So let's assume for a moment that I'm a nurse leader, I'm a CNO, and I'm in a hospital in a state that has one of those bans or one of those restrictions. I'm just trying to think about I'm listening to this podcast right now and I'm like, wow, this is something that I never thought of, or I thought of and I've not paid close enough attention to. And my first step clearly probably is to engage legal and or risk management or whatever the appropriate structure is my organization and say, hey, I
Yep.
think we have a problem. Let's figure out what we can share with our nurses. And if we're able to get somewhere on that, we develop a policy, we develop an education plan, then we put it out. We put it out through a town hall. We put it out through a health stream. We get our educators together. They go to staff meetings and they put the information out. We target the appropriate units, the emergency department, the OB departments, maybe surgery is an appropriate place as well. And we trickle down to the other units if and when it's appropriate, but we hit our core targeted areas first. That clearly is a great solution. My concern is, though, Lisa, and I alluded to it earlier, I'm the nurse executive and I go to legal and I deal with an attorney that doesn't want to put a flag in the sand and say, this is what you can educate your nurses on. And I get a wishy-washy answer or I'm not really sure. I'm not really. So what do I do in that scenario other than continue to advocate for my nurses? We're going to have a problem. It's a matter of time. It's a ticking time bomb. But what do I do? Do I shift and is this a place where nursing association should be really stepping in? Should I be going to my state nursing leadership association, so the MONL or somewhere around that, or that specific state hospital association and say,
Mhm.
we need to make sure that we're giving the same education at every hospital in the state of Texas or Idaho or whatever the case may be. So
Right.
what is the standard going to be here from a hospital association perspective that then we can take to the attorney at the hospital and say, this is what the X state hospital association says that we need to do this in the hospital. And then there's a little bit more leverage. Is that the strategy? Because
Yeah.
I'm worried that you've got nursing leaders that are out there because your study is about the frontline leaders saying, nobody's telling us anything.
Mhm.
My guess, I don't have the research to substantiate that. My guess is if you went to the nurse leaders, they would say, we're trying, we're not getting anywhere from the lawyers because they themselves don't know what to do because it's so vague and ambiguous.
Right. And I think that's a real problem, right? Because when laws are vague, people obey in advance, right? They over comply,
Yeah.
right? So, whereas, and for any nurse leaders out there who are concerned about this particular issue, there's an organization called If, When, How, which talks about the legal ramifications and sort of the differences between providing medical advice and providing information. So, in other words, if I have a patient who comes to me who's having a miscarriage at 16 or 17 weeks, but it is not complete, and in my state, I can't do anything, or hospital has decided, but in whatever way, like nothing can happen here. So if I say to this patient, you should go 300 miles north and get care there, right? You personally should take care of this in Illinois. That's giving medical advice. But if I say this care is generally available in the following states, I am providing information. I am not directing that person to any particular course of action.
Has that legal theory been tested? I buy what
Well,
you're selling.
none of
but
this
has
has been tested is
Okay.
the problem.
Yeah. Okay.
None
So
has
even
been
doing
tested.
that and providing information, that
Right.
legal theory has not been tested.
No, none of it has, nor has it intervening before a pregnant person is like blood pressure in the toilet from hemorrhage, right? So
Fair.
the thing is that, and both of those things would be seen as completely appropriate care if we had some test cases, right? If we had people willing to essentially be prosecuted for that.
Yeah.
And I think that's not fair to say to somebody like, hey, you should absolutely do what's best for your patient. We're going to prosecute you, but we're pretty sure that you'll be the test case and it'll be fine. That's not ethical either to ask that of people. So in this case, it has to be not an individual's problem, an individual nurse leader, an individual provider, an individual staff nurse. It can't be one person testing the waters. It has to be an institutional response in some way. So as a leadership team, you need to come together and get your legal counsel and say, we need to come up with something that we can make clear to our nurses. Because if I'm a nurse, and a lot of our nurses had no idea that they had care limiting legislation on the books, or that it applied to pregnancy emergencies. They're like, oh yeah, no, that just means you can't go to a clinic in your pregnancy. It doesn't mean, oh, if you come in here dying from hemorrhage, but the fetus still has a heartbeat, I can't take care of you. They don't understand the application of those laws in real time for emergencies. So first of all, when we talk to people about that and they understood, like, oh, it applies to that, they were furious that they didn't know anything, because they would have been like, I would just prep the patient for the OR, right? Like
Right.
they didn't know that this was no longer an option for care. And so I think it's really the obligation of leadership to make it clear, hey, stuff has changed. And right now, this is how we're approaching this, right? Like and even to things like when we talk to people, we ask them about, do you document? If your patient has an incidental finding of pregnancy, like they came in for an x-ray or something, right? Are you going to put that in a note? Or are you going to just like not put that anywhere, right? Because in some states, those things are true. So what are people doing about that? How are we documenting? HIPAA is apparently no longer a thing for pregnant people, nor is EMTALA in a couple of states, right? So how are we protecting our patients? That's also a discussion that nursing leaders need to have around electronic medical records and documentation and who gets access to those records. All of these things need to be discussed, and none of them are being discussed, right? So the obligation, the ethical obligation here is, in order to take care, to provide a safe environment for both your staff and your patients, this information needs to be disseminated.
Any closing thoughts as we wrap up this episode?
The idea of complying in advance and sticking your head in the sand here doesn't mean you're going to be immune. Ignorance of the law, getting back to what I was saying, a lot of the nurses didn't even know that these laws existed or that they pertained to emergency patients. Ignorance of the law does not protect you. And so when you don't tell your nurses what's illegal and what's not, then you're setting them up, especially in a state like Texas, which has civil enforcement. So some of the nurses in Texas who are more in the know, or like, if I tell a patient, like, hey, you should go to New Mexico and you can get care there, and somebody overhears me and reports me, like that's $10,000 in a year in jail for giving patients what in any other era, 5 years ago, would have been absolutely normal, good care.
Yeah.
And so that shift in what the hospital is willing to support their nurses and providers in needs to be communicated.
The title of the article is Medical Legal Communication Among Emergency Nurses in States with Abortion Bans, Implications for Nursing Leaders. You can find it in the Journal of Nursing Administration. It's in the April 2025 edition. Dr. Lisa Wolf, thank you again so much for joining us today.
Thanks for having me.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.